A very good afternoon to all of you. And today I'm going to talk about cardiac MRI versus PET for assessment of myocardial viability. I'm a SCMR level 3 certified FSCMR cardiac radiologist, and I'm currently working at ESCC Hospital. And this talk is intended for the cardiac surgeons, the cardiologists, and even the young cardiologists who are young radiologists. I'm sorry for who are trying to understand cardiac radiology. So the question comes, what is viability? So viability is basically the myocardium which is dysfunctional, which has reduced EF, but it can recover if we revascularize the patient. So there are two terms usually used in cardiology, which is hibernating and stunned. So the hibernating myocardium is a myocardium that has reduced blood flow and reduced function, whereas the stunned myocardium is a myocardium which had reduced blood flow at some point, but then the blood flow was restored. However, the function is still reduced. And if we revascularize these patients, the chances of recovery are great. And that is the target patients that we are trying to find using a myocardial viability study. So now they are traditionally echo has been used, and it has been postulated that if the myocardium is thinned out, then it's probably dead and not viable. However, there are multiple articles now that we all know that lack of wall thinning is actually not a good marker for viability, and the 6 to 8 cutoff is actually has a very low sensitivity and specificity for recovery. The lack of LG is the strongest predictor for recovery and increased end diastolic thickness following revascularization, and the likelihood of recovery parallels to infarct transmurality, regardless of the wall motion anomalies and regardless of the age of the infarct. Now, there is a natural question that comes. PET has been in market since long, and now MR is coming up and catching up soon. So, which is better for assessment of viability, MRI versus FDG PET? And I like to bring your attention to this article, which was published in Journal of Nuclear Cardiology, and they concluded that both have comparable diagnostic parameters for assessment of viability. So, both works. But then I would still say MR is better, and why? I'm going to prove this in the next few slides. Because PET is actually costlier. It has a complex and a long protocol. There is interference of FDG uptake by medications such as levothyroxine, diabetes, age, sex, heart failure patients. Then you will not be able to see the small subendocardial areas of necrosis, and it will still give you some radiation up to 7 to 9 millisieverts. When you look at LG by MRI, it has a better capability to detect the subendocardial defects. It shows a good correlation between the perfusion and the metabolism mismatch. Then there is a conventional gold standard. It's a conventional gold standard for hibernating myocardium. There is no radiation. The technique is relatively simple, and it will allow you to assess for post-MI complications. So let us look how does MR do all these. So MR has these host of sequences. These are the cine images where we see where using these we see the wall thinning function, shunts, flows, and all that stuff. This is the edema sequence where we look at myocardial edema. These are the mapping sequences which helps us to see interstitial fibrosis. That's the scar imaging where all the black myocardium is normal and whatever is white is a scar. And then we have the rest and stress perfusion using adenosine. So there is this article that just came in JAC where they postulated that cardiac MR in evaluation of LV remodeling in post-MI patients, and they said that CMR is a modality of choice in post-MI patients because it can reliably inform myocardial function and structure, including the infarct size, for serial assessment of LV remodeling and risk stratification post-MI. And this was the most important slide in this article. And if you do a CMR in hours to days post-MI, we have these sequences: the perfusion, T2 weighted imaging, mapping, LG, and T2 star. And using all these, we can see the infarct size, the myocardial area at risk, microvascular obstruction, intramyocardial hemorrhage. If you do a MRI days to weeks after the event, then you can, using CMR, we can see diffuse and focal edema, fibrosis, and the extent of scar. And if you choose to do MR months to years post MI, then we'll definitely see about the LV dimensions, functions, the wall motion anomalies, the desynchronous LV contractions, scar, transmurality, and remote and diffuse fibrosis. So whether you choose to do a MR in hours to days or months or weeks or years later, in every condition, MR is going to give you some valuable information which will change the patient management. Now let us look at a few cases. So this is a case of CAD and with a LAD territory obstruction, LAD significant disease in LAD. You can see there is a wall motion anomaly in the LAD territory with the LV apical thrombus. And then when we look at the scar pattern, this you see there is a scar in the LED territory. This all white area is a scar. But this scar is involving 50% of the myocardium. So this LED territory is viable. But then we can also see there is this black spot within the scar, which is microvascular obstruction. And you can also see the LV apical thrombus, which is seen as non-enhancing area in the in a long LG images, long TI LG images. So in this patient, you see that the LED territory is viable except the LV apex, which is showing a transmural scar. And then there are areas of microvascular obstruction and there is a LV apical thrombus. Now, let us look at another case. This is a patient with had a TVD. Again, you can see the LV significantly dilated with markedly reduced function. It was 22% on calculation. There was LV thinning, wall motion anomalies, then the ischemic pattern scar, as you can see on these post-contrast PSI images. And then you can see the areas of black within the scar, which are microvascular obstruction. And these areas of microvascular obstruction actually correlate with poor prognosis because these patients tend to have more of arrhythmias in the post-MI days. And therefore, it confers a poor prognosis on these in these group of patients. Besides that, you can see this area of pericardial enhancement overlying the area of scar. So there is a post-infarct pericarditis associated with the MI in this patient. So what all CMR can do? It will tell you about the viability assessment, whether the myocardium is viable or not. It will tell you about the microvascular obstruction and the thrombi, RV involvement, post-infarct pericarditis. Sometimes you see this blood seeping between the myocardial layers, which is called intramyocardial dissection. And then you can also see the LV rupture and the thrombus within the ruptured pseudoaneurysm in the inferior wall of LV, that is RC territory. And then sometimes you can also see these septal ruptures with VSD formation and a left to right shunt as in this patient. So these mechanical complications post MI are very important because they changes the management and how you want to treat your patient. So you can see here, this is the defect that you are seeing with the shunt from left to right. Now you can also do a stress cardiac MRI using adenosine. So when you use adenosine, you see these kind of perfusion defects as you are seeing in this RC territory in this patient. And then when you do a post contrast images, you do not see any scar in the corresponding area. So this is actually ischemic myocardium but not scar. On the other hand, when you see a perfusion defect but a scar in the corresponding area, then you know that this myocardium is actually scarred and not ischemic. But you can also see patients when you have ischemia in one territory, as the LAD territory in this patient, that where you have this perfusion defect but no scar. And then you have a scar in another territory, which is the RC and the L6 territory in this patient. So using a stress cardiac MR, you can actually see all the territories and will assess for ischemia and scar in each of these territories. Now, this patient came to us recently with a history of TBD, and he had multiple procedures, PTCA done, and at least three cath angios were done. The patient still remained symptomatic, improved for a while, then started feeling sick again, and the last echo showed dilated LV with severe systolic dysfunction and eccentric MR and dilated LA, I'm sorry. And he came for assessment of myocardial viability. Now, when we did the cine images, we found again the same thing, dilated LV, reduced function. But what was striking in this patient was the post-contrast images. So on the post-contrast images, you see this subendocardial focal scar in the LAD territory, but otherwise not a lot of scarring as I would expect for this patient who is so sick. But then we saw this mid-myocardial pattern of scar, which is actually a non-ischemic pattern and which was not actually expected to be seen in a patient of ischemic heart disease. Looking further, I found these nodes in the mediastinum, so I went further and did a CT for this patient. I found these non-caseating nodes with lung findings all in keeping with sarcoid. So this patient actually had a pulmonary and a cardiac sarcoid along with ischemic heart disease. And this is actually a case of dual cardiomyopathy where we have both ischemic and non-ischemic components. Now, this recent article by Parag Bhavaskar and others showed that non-ischemic and dual cardiomyopathy in a patient with CAD is actually quite common. It's seen in out of every six patients. And these have long worse outcomes compared to ischemic cardiomyopathy. And these contribute to lack of prognostic benefit in coronary after coronary revascularization. So all these things cannot be usually seen with PET. You are sending a patient for viability thinking that it is just ischemic cardiomyopathy, but coincidentally we found that along with ischemic, he also has a non-ischemic component that is contributing to his reduced EF, and we need to fix that if we really want the patient to improve. So there is no comparison actually between cardiac MRI and FDG PET. MR is actually the clear winner because it is easily available, it is cheaper, it's more reproducible, it's simpler with a shorter procedure, there is no radiation involved. It is safe in renal diseases when we use group 2 agents, and it offers a lot beyond viability, which are important in clinical decision making for the cardiologist and the CTVS surgeons. That's all for today. That's a team. I'm very grateful to them for all the hard work they do. And you can reach out to me for any questions or comments that you have on my email address. Thanks a lot and have a good day.